Well, I'm delighted to be here in Amsterdam at EHA talking to the Lymphoma Hub, and I'm basically going to tell you about what I presented yesterday, which was the MABCUTE study. Now, the MABCUTE study was an interesting study and basically addressed the question of whether extended maintenance in the context of follicular lymphoma is of benefit over and above 2 years standard treatment. So the trial included almost 700 patients, and they all had relapsed refractory indolent disease, both follicular, Waldenstrom's and marginal zone lymphoma. They were then treated with chemotherapy plus rituximab as per standard of care, although the rituximab was given subcutaneously. After a period of treatment, 6 to 8 cycles, if they were getting a response, they then had 2 years of subcutaneous rituximab as per standard of care. So that's the standard treatment. So patients who are at the end of that 2 years, who remained responsive to the treatment, were then randomized to either completing therapy there, which would be what we currently do, or extended maintenance until progression. So basically you're asking in that group of patients who've had benefit from treatment and maintenance, and it's just those patients who you would see in clinic who ask, would it be beneficial for me to continue? Because sometimes they're a bit nervous about stopping rituximab. So that group of patients, continue or stop. So first things first, the important thing was that there was no additional toxicity with the rituximab given subcutaneously over intravenously. So that's a reassurance for everybody, and we all have moved to subcutaneous rituximab, certainly have in my country. So there's no additional toxicity. And perhaps interestingly, but surprised I think many of us, that in the extended maintenance you didn't get any additional toxicity either over patients that were just on observation. So you weren't seeing an increase of infection risk or neutropenia, which is what some of us may have thought. But then I suppose patients who were going to get those problems may well have fallen out of the original first 2 years maintenance. The primary endpoint of the study was progression-free survival at that point of randomization, and essentially there was no difference between the two arms. There were very few events, mind you, so very few patients were progressing or came off the study on the subcut or in the observation study. So no difference with respect to progression-free survival, and absolutely superimposable overall survival. So from a statistical point of view, you could say that it wasn't powered enough, there weren't enough patients, there weren't enough events, and you would need more patients and longer follow-up to absolutely definitively prove that extended maintenance was no benefit. But within the confines of the study that was done, and there were almost 300 patients in that randomization, there was no difference between those two arms. So extended maintenance over stop, no difference. So that's reassurance for patients and clinicians that at the end of that 2 years maintenance, you can stop treatment.